Well, thank you very much for inviting me. Thank you for inviting me back. That must be a good sign. and for your kind introduction and the opportunity to update you on the Psoriasis Priority Setting Partnership. So my talk looks like this. I'm going to start by telling you a little bit about the Psoriasis Priority Setting Partnership, or PSP. I'm going to touch on our outputs from the Psoriasis PSP. I'm going to reveal the top 10 research priorities for psoriasis, and finally share with you what our next steps are. So as many of you in this room will know already, a priority setting partnership, or a PSP, is a process to help patients and clinicians work together to agree which are the most important issues or uncertainties within a particular disease of interest, with the aim of influencing the prioritization of future research in that area. And the entire process is facilitated by an organisation called the James Lind Alliance, or the JLA. So the JLA is a non-profit-making organisation which was established back in 2004 by Sir Ian Chalmers. It's funded by the NIHR, and the JLA believe that research often overlooks those questions that patients, carers and clinicians consider most important, and that many areas of potentially important research are therefore neglected. The JLA have observed that even when researchers do address questions of importance to patients and clinicians, they often fail to provide answers that we find clinically useful. So the purpose of the JLA is to address that mismatch between what researchers want to research and the practical information that is needed day by day by patients and healthcare professionals. So the JLA has a way of functioning to help bring together patients, carers and clinicians in order to identify and prioritise the most important uncertainties or unanswered questions about the effects of treatment or about a disease process itself. So the JLA is fairly obviously named after James Lind, and James Lind is depicted in this beautiful artwork here. James Lind was a Scottish physician in the Royal Navy in the 1700s, and he is considered to be the pioneer of clinical trials because he conducted one of the first ever clinical trials and provided the evidence that citrus fruits cured scurvy. Now, the idea of bringing together clinicians, patients and carers to discuss research priorities seems really obvious. Why shouldn't those affected have a chance to share their lived experience of a condition and to influence their future? So because of that, the overarching aim of a PSP is to help ensure that those who fund research are aware of what matters most to patients and clinicians. And so PSPs help make research happen by promoting the top 10 priorities to key people and organisations such as research funders, researchers and the wider research and policy community. But why is it that we did a PSP for psoriasis? Well, we're all aware in this room that psoriasis is a common disease affecting about 3% of our UK population. We all know that psoriasis can have a significant and devastating impact on quality of life, in addition to predisposing sufferers to other related health conditions. We know that psoriasis represents a substantial economic burden on the NHS, and we know that access to appropriate care that addresses the high healthcare burden and complex interlinked physical, psychological and social needs of those who have psoriasis can be poor. And we also know that academic researchers and commercial interests have traditionally held pivotal roles in setting the research agenda for psoriasis, with patient views given much less emphasis. And so there remain many unmet needs and unanswered questions about psoriasis, which, if addressed by relevant, focused research, could improve clinical outcomes for patients and clinicians who treat them. So in order to redress this balance, it was the vision of the Psoriasis Association to fund a psoriasis priority setting partnership. And the objective was to influence future psoriasis research undertaken in the UK by sharing the research questions that patients, carers and clinicians considered were the most important, and promoting those to organisations who fund research. However, bringing healthcare professionals, patients and carers together, ensuring each has an equal voice to agree anything at all, is challenging. And that's where the James Lind Alliance are absolutely crucial to PSPs. So our psoriasis PSP followed the standard 5-stage methodology established by the JLA. Our work was supported and facilitated by the JLA in the person of Mary Rose Tarpey here on this slide. And she was the lead JLA advisor for the psoriasis PSP throughout our psoriasis PSP journey. It was my privilege to lead the PSP, which, although was based in Manchester, strategically reached out to individuals, institutions and organisations across the UK and internationally. And in order to do this effectively, we collaborated and worked in partnership with the organisations shown on this slide here. First and foremost, the Psoriasis Association, but also the UK Dermatology Clinical Trials Network from University of Nottingham. Professional organisations were involved, including the British Association of Dermatologists, the British Dermatological Nursing Group, and the Primary Care Dermatology Society, and international groups, including the International Psoriasis Council. And all our work, as I've said, was supported and facilitated by the James Lind Alliance. As one of the central tenets of a PSP is to bring together clinicians, patients and carers to establish those issues which matter most, guiding the work of a PSP is the steering group. And here on this slide is the Psoriasis PSP steering group. The individuals, many of whom are in this room, and through a lot of very hard work, ensured that our entire endeavour had balance and both a patient and a healthcare professional perspective. But in order to ensure that a PSP is valid, able to produce a credible and representative output, which offers a fulcrum for change, investment and research focus, is outreach by the steering group and partner organisations to all stakeholders, all healthcare professionals and patients within a disease area, and in our case, within the psoriasis community. And we gave this considerable thought, as it was essential that the psoriasis PSP was inclusive and enfranchised all opinions held by those in the wider psoriasis community. And I'll come back to how we actually did this in a few slides' time. So we started off the PSP by conducting a survey. So this was survey 1. And this was to specifically find out what questions people had about psoriasis that they would like to see answered by research. And this was open to those with lived experience of psoriasis and to healthcare professionals. We launched Survey 1 at the British Association of Dermatologists annual meeting in Liverpool in early July 2017, and we gathered questions using online and paper-based submissions. Now, I know it seems a very small point, but this was actually important. Inclusivity was very key to all of our work. Not everyone is online, and so here we have a paper return box for people who wanted to fill out a paper-based survey. Admittedly, the vast majority of our returns were through the online platform, which was hosted on the Psoriasis Association website. But we also reached wider than that. We reached out to the wider psoriasis community through our partner organisations and through the individual efforts of our steering group members and their networks. So we promoted the PSP to dermatology through the BAD. We had a publication early on in this process in the British Journal of Dermatology. We also reached out through the British Society for Investigative Dermatology and the British Society for Medical Dermatology. We worked with the British Society of Rheumatology to involve rheumatologists. We contacted GPs through the Primary Care Dermatology Society, but also through the Royal College of General Practitioners. We reached out to the British Dermatology Nursing Group, who were excellent advocates for the psoriasis PSP. We published in the Journal of Dermatology Nursing, but we also had support from the Royal College of Nursing, from the School Nurses Forum, and from the Community Practitioners and Health Visitors Association. Through our collaboration with the University of Nottingham, we utilised the networks of the UK Dermatology Clinical Trials Network and the Cochrane Skin Group. We reached out to psychologists through our steering group representative for psychology, Chris Bundy. I know many of you here will know Chris. And we wanted to ensure representative sampling across the UK. And so one of the things that we did on a weekly basis was we monitored the return from the home nations very closely. And for example, when we had a little challenge from Wales, we engaged with Wales very specifically by approaching the cross-party group on skin at the Welsh Assembly and Skincare Cymru, and they raised awareness about the PSP in Wales, and we saw that reflected in our return. We publicised the PSP and we made paper copies of our survey available through a large number of secondary and tertiary care adult and paediatric psoriasis clinics across the UK. We sent materials home in children's school bags, and we had information made available in community centres and GP surgeries. We approached Mumsnet and other parenting websites, men's health websites, and the steering group, supported by an extremely well-organised publicity campaign orchestrated by the Psoriasis Association, blogged, tweeted, and used a variety of social media platforms to encourage participation. And so in our first survey, when we closed, we had over 2,130 questions submitted by over 800 individuals. And this included over 70% of questions from patients directly, over 20% of patients coming from healthcare professionals, more than half of the respondents were female, and 10% were from Black and minority ethnic groups. So having received these 2,133 questions, we then spent about 6 months working with these individual questions. And Rabia Majid Aris, supported by the steering group, led on this work. So the first thing that we did was we added in to the 2,133 60 relevant questions that we had found through literature searches using systematic reviews valid within 5 years of our project, and took out questions which were out of scope or had been answered by systematic reviews. We also removed questions about health service delivery, and I'll tell you a little bit more about that in a few slides' time. And so when we had our final group of questions together, we started to work through those questions again, grouping and theming questions together and clumping them together to produce a list of 55 indicative questions, each of which reflected the overarching themes of the original submission. So having got these 55 questions, we then conducted a second survey. This was survey 2, where we invited healthcare professionals and patients to vote for their own personal top 10 questions from our list of 55 questions. And based on the votes from over 1,150 individuals, we were able to then identify a short list of 20 questions, and this included the top 10 questions ranked by patients and carers and the top 10 questions ranked by healthcare professionals. And these were taken to the final priority setting workshop, which we held in London in September 2018. And at that final priority setting workshop, 26 delegates, evenly split between healthcare professionals and patients with psoriasis, facilitated by 3 JLA advisors, reached consensus on the top 10 research priorities for psoriasis. So although we were primarily focused in defining and finding the key research priorities for psoriasis, given the material submitted to us, the psoriasis PSP actually has 3 important outputs. And before I share the top 10 research priorities with you, I will touch very briefly on our 2 other valuable but unanticipated outputs. So you will remember that one of the first steps in the whole process was to separate questions submitted into the psoriasis PSP into those that were true uncertainties and those that we called unknown knowns, questions where there were already answers available in the literature. So the unknown knowns represent those issues which have been misunderstood by healthcare professionals and where those with lived experience with psoriasis need further support or clarification. And they offer us an opportunity to better target communication and education for both clinicians and patients. This was a really important first output for us, and if you remember was the focus of my talk at last year's association conference and AGM. And just to touch very briefly on our third PSP output, health service delivery, which is still a work in progress, when we were refining the submitted questions into themes, we realised that we had almost 200 individual submissions, which was approximately 10% of the total material submitted on the theme of health service delivery. So when the steering group reviewed that raw material, we considered that if these submissions remained within the PSP process, they would likely be reduced to maybe 1 or 2 indicative questions, and we therefore risked losing a lot of very valuable, rich material. We risked losing an opportunity to highlight the significant unmet needs in psoriasis care in the UK. So we're currently working with these data at the moment, but essentially I think we have an output which describes a blueprint for how to personalise care for patients with psoriasis, designed by those who suffer with psoriasis and by those who treat them. And perhaps it may be possible for me to share more about that aspect with you in future meetings. But now for the big reveal, the top 10. So in 10th place, we had a focus on disease management. What is the best way to treat sudden flare-ups of psoriasis? In positions 9 and 8, there was a focus on causes and consequence of psoriasis. Priority 9 was, is a person with psoriasis more likely to develop other health conditions? If so, which ones? And the 8th priority was, to what extent is psoriasis caused by a person's genes or other factors, such as stress, gut health, water quality, or change in the weather temperature? The questions prioritised in positions 7th and 6th focused on treatment of psoriasis. 7 was, why do psoriasis treatments stop working well? And when they stop working well, what's the best way to regain control of the disease? And in 6th, we had, does treating psoriasis help improve other health conditions such as arthritis, cardiovascular disease, metabolic syndrome, and stress? In 5th place, psychological support was the focus. The question, how well do psychological and educational interventions work for adults and children with psoriasis? And 4th was focused on relief of symptoms. What is the best way to treat the symptoms of psoriasis? Itching, burning, redness, scaling, and flaking. So the top 3. In 3rd, what factors predict how well psoriasis will respond to treatment? In 2nd, does treating psoriasis early or proactively reduce the severity of the disease, make it more likely to go into remission, or stop other health conditions developing? And the top priority was, do lifestyle factors such as diet, dietary supplements, alcohol, smoking, weight loss and exercise play a part in treating psoriasis? So these are the top 10 research priorities for psoriasis in the UK in rank order of priority. Now, having announced the top 10, this is where we're really at now, the next steps. And the next steps involve promoting and publicising them. The Psoriasis Association have been in the vanguard of this work, which has involved coordinating a very well organised publicity campaign, promoting the Psoriasis Top 10 to research funding bodies, publishing our outputs. We have 3 papers published to date, 1 paper currently under review, 3 more manuscripts in preparation. And next month, I'm travelling to the World Congress of Dermatology to share the Psoriasis Top 10 with a global audience. But what's particularly special about a PSP is that although the top 10 receives considerable focus, this is our psoriasis top 10, actually, at the final workshop, we prioritised the top 20 questions. And here, I'm showing this slide for the first time, here are our, in rank order of priority, questions 11 to 20. And furthermore, all the themed uncertainties, all 55, remain within the process. Nothing is lost from a PSP. All 55 uncertainties are publicly available via the JLA website, and all are identified as important research issues. At 21 to 55, they are not ranked, so they're just part of the total output. So in summary, academic researchers and commercial interests have traditionally held pivotal roles in setting research agendas, with patient views given less emphasis. However, the psoriasis PSP has given patients a voice and identified important questions that need to be answered not only by research, but through better communication with patients and through improved education of healthcare professionals. Our top 10 priorities, which represent the key issues faced by psoriasis, will inform the translational research agenda for psoriasis, and they represent everything that the psoriasis community feels is really crucial. Addressing the psoriasis top 10 and the other psoriasis PSP priorities will ensure that future research is relevant for the needs of people who have psoriasis and will result in better clinical outcomes for patients and for those involved in psoriasis care. There are, of course, a large number of organisations, professional bodies and individuals who've contributed to the PSP. However, it must be acknowledged that none of our work would have been possible without the vision, passion, support and sheer hard work of the Psoriasis Association. Thank you very much for listening, and if you have any questions, these are the top 10 questions, but if you have any questions for me, I'd be very happy to answer them.